everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Kimani Hendricks, Multimedia Communications Coordinator, and this afternoon, or early evening, I'm joined by Dr. Ben Thrower, who will be talking about MiSfires, the malfunctioning MS immune system. We will address all questions and comments after the presentation is over, but for now, I'll just introduce Dr. Thrower. He is the Senior Medical Director of Multiple Sclerosis Foundation. He enjoys contributing to our quarterly magazine. He is the Medical Director of the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia. And he previously served as the Medical Director for the Holy Family MS Center in Spokane, Washington. I'm not sure if he still dresses up as Jack Sparrow, pirate, or I imagine his grandson Sam is a little older, but I heard that he has a new granddaughter, Opal. So congratulations to you, Dr. Thrower, and it's always good to co-host with you, and I'll turn it over to you.
Great. Thank you very much. And thank you to everyone at MS Focus for all that you folks do and for making this such an easy format to get information out on. I think Jack Sparrow is going to be resurrected this year. I figured after his trials and tribulations, it was probably appropriate since he's been back in the spotlight for better or worse. Mm-hmm. So this is a topic that I thought would be of interest to our listeners and viewers. We think about multiple sclerosis as a neurological condition, which it obviously is, but it really is an immunologic condition. And as we get more and more treatment options, now and for MS, and we see things on the horizon, ultimately, most of these therapies do something in the immune system. So if MS is an immune problem and our therapies are ultimately immune therapies, it probably would be nice if we have a common language so that people have an understanding of what the immune system is, what it should do, and where is multiple sclerosis throwing some challenges into that normally functioning immune system. So we could spend hours and hours on immunology. Immunology has been compared to a never-ending onion. You peel back layer upon layer upon layer, and it just never seems to end. Obviously, I'm not going to torture you for hour upon hour with immunology, but I did want to spend a little bit of time just talking about some terminology and concepts, and then talk specifically about MS. So what is the immune system when we say that? So it's a complex set of organs. So unlike, say, the heart or the liver, where you have an organ, with the immune system, you have something that's spread out through the human body. So it's a complex network of organs and cells and proteins that are really designed to do something. They are designed to protect us. They protect us from the outside world that might want to harm us. So bacteria, viruses, parasites, things that are from the outside that might want to come in and cause disease, but also protects us from the inside, protects us from things like cancer. A normally functioning immune system should protect us from autoimmune conditions. So conditions where the immune system is attacking something that it shouldn't be attacking, namely us. So that's what the immune system is. There's some terminology that we should think about. So all of us are born with something called the innate immune system. This is the immune system that doesn't have the capability to learn or to adapt. It is what it is from when you're born till the day you die. This immune system is there to protect you, and it's hardwired. As sort of humans evolved and really mammals evolved over millions of years, we developed an adaptive immune system. So this is the more highly evolved, complex immune system that can learn to react to new threats, and it can keep that memory for those threats in the future so that it doesn't have to go through this learning process every time. So we have an innate immune system and we have an adaptive immune system. Antigens. So antigens are molecules that elicit an immune response. We normally think of these as things that elicit a protective or inflammatory response. So things like germs, bacteria, viruses, parasites, cancer cells. But it can also be even things that are in food, proteins and chemicals. If you have an allergic reaction to something that you eat, that antigen in for instance, maybe it's a peanut protein, has elicited an immune response. Sometimes these are proteins on normal cells that help coordinate immune responses. So it's not always an attacking sort of foreign response. It can be part of our normal immune system as well. Antibodies are proteins that are made as an immune response to an antigen. So one of the important concepts in medicine in recent years has been monoclonal antibodies. So natural antibodies that we make are polyclonal. Poly means many. So when we say that it's an antibody is polyclonal, we mean that it's attacking a broad sort of variety of antigens. That's a natural antibody response. Well, we've been able to artificially manufacture in a laboratory monoclonal antibodies. So these are antibodies that only attack one specific antigen. So you are designing an antibody from day one in the laboratory to do one very specific thing. And some of the examples of that in our world would be medications like Tysabri, Ocrevus, rituximab, Lemtrada. These are all monoclonal antibodies. Evusheld, the COVID monoclonal antibodies that we used to give people protection against COVID, would be an example of a COVID monoclonal antibody. Technically, Evusheld is two different monoclonal antibodies, so you get two shots when you get it, but so it's actually two different monoclonal antibodies. Cytokines. So a lot of us had never really heard the term cytokine until the COVID pandemic started, and then you started hearing this term cytokine storm. So cytokines are chemical messengers that our immune system uses to help coordinate immune responses. Cytokines can be inflammatory or they can be anti-inflammatory. So when we think of a cytokine storm, we usually think of this massive release of inflammatory cytokines that causes an inappropriate inflammatory response. Chemokines are a specific type of cytokine. These are chemicals that are produced by immune cells at a site of tissue damage or inflammation. And what chemokines do is they call in other immune cells to that site of damage or infection. So they might be calling in inflammatory cells to cause more inflammation, or they could be calling in regulatory cells to sort of tone down that inflammation. An important term in immunology is CD. So we think about some of our MS therapies. We think about, for instance, the Ocrevus or Rituxan or Kesimpta. These are all anti-CD20 monoclonal antibodies. So when we say CD, what do we mean? So CD stands for cluster of differentiation. These are sort of proteins that are expressed on the surface of different immune cells, and these identify what type of cell it is. So in the little diagram on the bottom, you can see all of the different CD antigens or numbers that T cells can have. And you see on the other side the CD antigens that B cells can have. So these are a way of sort of differentiating what a cell is and what it does in the immune system. With all of these CDs, you can make a monoclonal antibody to any one of these CD proteins on the surface of a cell. So the possibilities, going back to our monoclonal antibody sort of the definition, the possibilities with monoclonal antibodies are limited only by the complexity of the immune system. So the blood-brain barrier, really important concept in multiple sclerosis and normal immune function. So the blood-brain barrier is a system of blood vessels and cells that basically forms a wall, if you will. It's a selective wall that from between the blood vessel side of things and the brain and spinal cord or central nervous system side of things that is very picky about what it lets get through. It's only going to let certain types of cells, certain nutrients, things that it wants to get into your brain and spinal cord for a healthy brain and spinal cord. It's only going to let those things get through. When it's not working the way that it should, things that shouldn't get through may be getting through, things like inflammatory cells. So shifting to one of the most important types of cells in the human immune system, T cells. So two of the big sort of delineations with T cells are CD4. Here's that sort of term again, CD. So CD4 and CD8 are sort of ways of differentiating T cells. CD4 T cells are generally thought of as being helper cells. They help the immune system mount an immune response. There's a subset of those cells, and I apologize for the noise in the background. Some of the subsets of CD4s are what we call TH cells. So these are subsets of CD4. There's TH1 and TH17, which are generally felt to be more inflammatory. There's TH2, which is generally felt to be a little bit more regulatory. We'll come back to that concept and how that relates to multiple sclerosis. There's also something called a TH0 cell. That's an immature cell, type of CD4 cell that hasn't learned to be anything in life. It's going to grow up in life to be one of these others, TH1, TH17, or TH2. CD8 cells are generally thought of as being kind of suppressor cells. They help turn off the immune response. One of the most important concepts in the human immune system is that everything is about balance. If something upregulates inflammation, there should be another part of the immune system that downregulates inflammation. And it's when this balance is thrown off that we see problems, either an overactive immune system with autoimmune diseases or maybe an underactive immune system in different things that might compromise the immune system. So B cells grow up in life to become something called plasma cells. Plasma cells make antibodies. The other big job of B cells in the immune system is that they can help coordinate the T cell response. Another important concept in the human immune system is that everything in the immune system tends to dance with everything else. Nothing exists in isolation. So whereas B cells' major job is to make those antibodies, they also can serve as antigen presenting cells. They take something that might be foreign, for instance, a piece of a bacteria, they process that cell, they hand it to an immature T cell and they say, here, I think this is something that you should attack. So they're serving to coordinate the immune response by serving as antigen presenting cells. In the MS world, we tend to focus in the B cell lineage mainly on CD19 and CD20 B cells. So we think again of our B cell therapies in multiple sclerosis, Ocrevus, Rituxan, Kesimpta, Truxima. These are anti-CD20 B cells. They're antibodies that are binding to that CD20 receptor and targeting that specific B cell for elimination. So why are we interested in CD19 in the MS world? We're interested in CD19 because our blood tests that we use to monitor immune function generally gives us CD19 results rather than CD20 results. So generally in B cells, the CD19 and the CD20 receptors travel together. So what one is doing, the other is doing. So if I knock down your CD20 cells, I'm really knocking down cells that also express CD19. So if you're on one of these B cell therapies in MS, one of our goals is that those CD19, CD20 cells should be close to zero. That shows us that the drug is doing what it should be doing. So when we are talking about looking at the effectiveness from a lab test standpoint of your Ocrevus or Rituxan, we're going to say, well, your CD19 count was zero, using that CD19 to tell us what CD20 was doing. macrophages. This is kind of one of my favorite cells in the immune system. So macrophage is Latin for big eater. I compare the macrophages to the Pac-Man of the immune system. They basically just go around eating stuff. One of the other things that they can do is they can also serve, just like B cells, as antigen presenting cells to T cells. So that's kind of an overview of kind of the components of the immune system, how things should work. So what goes wrong in multiple sclerosis? I think one of the greatest myths of the MS world has been that MS is an underactive immune system. It's not. MS is a dysregulated immune system that really is in some ways specifically overactive as it relates to your brain and spinal cord. You have an inappropriate attack on the myelin and axons in the brain and spinal cord due to this dysregulation. That inappropriate attack and immune dysregulation results from a complex interplay between genetics and the environment. One of the, I think, the most important discoveries this year so far has been a better understanding of how Epstein-Barr virus results or may contribute to this dysregulated immune system. The researchers at Stanford University and their research department really took us, I think, a big step forwards in understanding how the Epstein-Barr virus can sort of help contribute to this immune dysregulation. We had always known, or at least for decades, have known that Epstein-Barr virus is one of a lot of viruses that can play a role in the development of MS, but how that worked was a little bit mysterious. And these researchers at Stanford have really sort of contributed greatly to our understanding. Hopefully that will now translate into maybe more therapeutic avenues and tools in our toolbox to help stop MS. So with MS, you can have problems with your T cell response, you can have problems with your B cell response, and you can have a leaky blood-brain barrier. And we'll take a little bit of a look at each of these. So on the T cell side of things, one of the problems in multiple sclerosis is that you can have a decrease in the numbers and function of T regulatory cells. So T regulatory cells, again, are cells that are going to help turn off that inflammatory response. They're kind of like the marshals, if you will, of the immune system. And if you don't have enough of those, in theory, you can have more inflammation. So that's one of the problems on the T cell side of the equation in multiple sclerosis. You can have increased numbers of autoreactive CD4 cells. One of the things that's interesting in the human body is we all have immune cells that will potentially attack us. The normally functioning immune system helps suppress those autoreactive cells, whether they're T cells or B cells. In multiple sclerosis, we appear to have too many of these autoreactive CD4 cells that are not being suppressed for some reason. When we look specifically at those CD4 cells, remember we said within that CD4 subset, we have a subset of a subset with these Th1, Th17, and Th2 cells. But think of it again as a balance. On this side of the equation, you have Th1, Th17, which is inflammatory. Over here, you have Th2, which is more regulatory or anti-inflammatory. And in multiple sclerosis, you kind of live here. The balance has been tilted in favor of those Th1, Th2 cells. We also can have increased numbers of CD8 cells. And we normally think of the CD8 cells as being more regulatory or anti-inflammatory. But again, one of the rules we set in MS is that things are complex. And just because a cell does one thing in one situation doesn't mean that it might not do something different in another situation. And what we know is that when the CD8 cells are in the CNS, they can actually start acting as pro-inflammatory cells, so they can kind of shift over to that more inflammatory side of the ledger. How about our B cells? Where do they go awry in multiple sclerosis? So the normally functioning immune system helps put a lid on the autoreactive B cells out in our sort of periphery outside of the brain and spinal cord. So even though we might have B cells that want to make antibodies that would attack our own body, our immune system seems to keep those in check. Something about that check seems to go wrong in multiple sclerosis. So we may be letting some of those autoreactive B cells get through. They're going to make auto antibodies or antibodies that want to attack us. Some of these inflammatory B cells seem to really want to set up shop in the brain and spinal cord. So they make something called germinal centers. These are little factories, if you will, that are making these inflammatory B cells in the brain and spinal cord itself and promoting inflammation from within the brain and spinal cord on that side of the blood-brain barrier. These B cells that serve as antigen presenting cells, they may be part of the problem also. They may be sort of presenting antigen in an abnormal way and driving some of the inflammation that's driven by T cells. One of the questions that comes up with our B cell therapies was, well, how do they work? You know, do they work by decreasing these autoantibodies? And there's evidence that may not be the case. They may really be working more by affecting the antigen presentation to T cells. So when you put all of this together, this is actually a simplified sort of little diagram, and I don't expect people to digest this. I just put it up there really to illustrate how complex the immune response is in multiple sclerosis. And one of the other things that adds just one more layer to this complexity is that MS is really quite individual. So how one person with MS expresses their symptoms may be very different from how someone else has symptoms. That also translates down at the immune system level. So work done at Mayo Clinic years ago suggested that some people with MS appear to have MS that is really driven primarily by T cells and some of those T cell pathways that we talked about. Other people appear to have MS that's more driven by the B cells, and then there are people that appear to have contributions from both. One of the challenges that we have is we would very much like to have individualized, customized therapy to the individual with MS. If I could tell you that your MS is really driven more by T cells, I might pick treatment A. If it's more B cells, I might pick treatment B, and so on. We just don't have that capability yet to tell how a given individual's MS is working immunologically. A lot of this work that was done at Mayo Clinic was done through biopsies, and obviously we don't want to have to resort to brain biopsy to get that information, but there's a tremendous amount of work being done on surrogate markers that might let us tell in a given individual how their MS works and how we might best customize their therapy to that immune response. So MS is a complex disease and it affects a very complex immune system. MS can affect many different steps in that immune system. And when you take those first two statements, it would seem to be kind of daunting, but the opportunity in that is that every one of those steps represents a treatment opportunity. So with the advent of things like monoclonal antibodies, I think the possibilities are almost endless in terms of how we might intervene to stop the MS process. We have far more treatment options now than we did when I finished treatment or finished training back in 1992. And I think we're just going to see an ongoing explosion of different treatment options out there, and hopefully ultimately leading to the toolbox that lets us stop MS in its tracks, and then a second option that's going to let us sort of reverse the damage that's been done for people. So I think with that, hopefully that was not too painful. We work with medical students, and I always tell the medical students, boy, if you really are going to pay attention in one course in medical school, pay attention in immunology. It's daunting, but I really do think it is at the heart of so many of our health issues, and I think it is going to be at the forefront of where research takes us, not only in MS, but in so many other health conditions. So with that, we'll throw it open and see what thoughts or questions we have.
Sure. We do have a question in the Q&A, but before I get into that, I'll just let anybody know who is watching with us for the first time on Zoom. If you have a question, you can either type them into the chat box below or the Q&A box. If you choose to ask a question or leave one anonymously, you can use that feature in the Q&A option. If you would like to speak directly to Dr. Thrower, you can use the raise hand feature that's also at the bottom of your screen. And if you are on a mobile device and would like to raise your hand, just press *9 and then wait to be unmuted. And if you're on Facebook watching the live stream, just type your comments into the section below and then we'll answer them live here. So Elizabeth does have a question. She says, what is the normal CD20 B cell percentage on a lab test? And she says, in regard to that lab test, the lymphocyte subset test.
Yeah, so I'd have to look up on, so we use the Mayo Clinic assay. So what we use, and most labs call it the same thing, it's quantitative lymphocyte analysis. So it gives you the numbers of CD19, CD20, CD4, CD8. I have to look on that lab. I don't recall right offhand what the normal percentage is. And there is some variability from one testing center to the next within a little bit. They're all going to be fairly close to each other. So I don't recall right offhand what that absolute percentage is for CD20. And the reason we don't always pay attention to the normal number is because in treatment with MS, we're more focused on suppressing it, driving it down to 0. If you're on a B cell therapy again, we really want to make sure that it's not normal. We want it to, that CD19, CD20 number to be 0 or really close to it.
Karen has her hand raised. Can you unmute, Karen?
Yes, thank you. I have 2 questions, if I can beg for that. Number one, in taking a B cell a CD20 therapy, my understanding is that the B cell that it attacks, the CD20, is sort of a teenager in the growth process of B cells, and
Correct.
that B cells go on to become plasma. So what are the long-term ramifications of being on a medication that wipes out those teenagers that never grow up? That's probably an oversimplified
No, that's
thought.
perfectly stated. So there are a couple of things that we want to make sure. So you have memory B cells that B cell therapies don't affect. So you have, let's say you were vaccinated to something before you started a B cell therapy. You should keep that immunity based upon your memory cells. So drugs like Ocrevus and Rituxan and Kesimpta are not affecting your memory B cells. What they're affecting is your ability to form new memories. And so that's going to be hopefully a good thing from an MS standpoint. This has been very sort of obvious to us with the COVID pandemic. When we look at people who are vaccinated against COVID, who are on a B cell therapy, a lot of those patients are not making good antibodies because they're not forming, those teenagers are not being allowed to grow up. So one way that we get around that is by just giving you the antibodies with Evusheld or a product like that. The other thing that so part of the safety monitoring with Ocrevus is if we can get you vaccinated for all the things you should be vaccinated before you start Ocrevus, so you can form those memory cells, great. If we can't, we can think about things like Evusheld. We also want to make sure that B cell therapies are not doing more than they should do. Remember, we said everything in the immune system dances with everything else. So even though B cell therapies should really only affect the CD20 B cells, sometimes they will affect T cells. And so we look at the CD4 and CD8 counts, make sure those aren't getting too low. We look at the IgG levels, so immune globulin. One of the things we can see in patients on B cell therapies over time is that their total antibody production is starting to sort of creep down a little bit. And specifically with IgG and to a certain degree with IgM, the risk of infections, things like upper respiratory infections and urinary tract infections, appears to be higher in people who have lower levels of those of IgG or IgM. So in my B cell therapy patients, I want to look at your total lymphocyte count. I would like it to be normal or low normal, not too low, and then break them down. Look at the CD19 and then those T cell subsets and your IgG. Ideally, what I'd like to see is a normal lymphocyte count, a normal IgG, normal CD4, normal CD8, low CD19, and only the CD19 as a measure of what CD20 is doing. That's the only thing that's low. If the person is starting to see their lymphocyte counts drop a little, IgG drop a little, CD4, CD8 drop a little, I don't like to let that go unchecked. I don't want to wait until the person starts having infections. I would like to be proactive and make some changes. One of the easiest changes to make is just lower the dose a little bit and let those other sort of parameters come back up into a normal range.
I see. And my last, hopefully it's a yes/no question. If they do develop a vaccine for Epstein-Barr virus, do you think that that would eliminate MS?
I think if you could prevent Epstein-Barr virus, I think it would, I mean, in theory, based upon what we know, it should put a big dent in MS. The reason I hesitate to say absolutely yes is Epstein-Barr virus the only virus that can do it? I don't think that we know that for sure. There's been some indication that other viruses might have some potential, like human herpes virus 6, which causes roseola in kids. I think Epstein-Barr virus is the big player, though, so it would definitely put a big dent in MS.
Thank you.
Yeah.
We have another question in the Q&A. Jay wants to know if having insufficient vitamin D levels breaks down the blood barrier.
So low vitamin D levels definitely plays a role in a person's MS risk, and we think that it's through mainly T cell mechanisms. Most of the research on vitamin D has said that as your vitamin D levels go down, the number of T regulatory cells goes down and the number of inflammatory cells goes up. So it's probably more T cell mechanisms than it is blood-brain barrier mechanisms.
And Bridget, she kind of has a long question, but bear with me. Could chronic infection or inflammation in one part of the body, like eczema or something else seemingly unrelated, cause imbalance or dysregulation in the immune system, leading to autoimmune disease?
So I would say it's probably the other one. So the dysregulated immune system is what's causing something like eczema or these other allergic or sort of autoimmune type responses. If you have, so now you have, let's say, an autoimmune disease like MS. Now, if you have inflammation in another part of the body, it's going to make your MS unhappy. So as you generate inflammatory cytokines and upregulate the inflammatory response, you can see MS symptoms sometimes become more obvious. So at its worst, we call that a pseudo exacerbation. So someone who looks like they're having a relapse, when in reality, it's their urinary tract infection or their upper respiratory infection that's driving that. So I think it's, it's not that the eczema would cause the underlying autoimmune disease. It could sort of, it is the result of a dysregulated immune system. And if you have one autoimmune condition, it can make the symptoms of another autoimmune condition act up a little bit.
Gotcha. Sue wants to know, she says, you said genetics and environment can cause or affect MS. What if no one in your family has it? And how does environment possibly cause MS?
Yeah, it's a great question. So MS is complex genetically. So we know of over 200 genes that play a role in a person's risk for MS. So from a big picture standpoint, if you have MS, what's the likelihood that you have a family member with MS? It's about 10%. So 90% of the time, you can't find a family member with MS. There's a higher likelihood that you can find a family member with another autoimmune disease because the genetic substrate for autoimmune conditions appears to be pretty similar. So why one family member goes the MS pathway, someone else goes the psoriasis pathway, someone else goes the lupus pathway, we don't know, but only 10% of people with MS can find a family member with MS. So you could carry all of those genes to have MS and not have MS. You have to have the environmental piece to turn those genes on. And so the environmental pieces are, again, things like Epstein-Barr virus, low vitamin D levels, some other things that play a role, but probably not by themselves. They have to have some other, so things like obesity, especially in teenage girls, cigarette smoking. These are things that kind of help turn those genes on.
Yeah, that was a question that I was going to ask you at one point, but she already took care of it because I have heard people say that, MS is not hereditary, and yet genetics does play a small
Yeah.
part in getting it.
And so what I tell folks is MS has a genetic component, but it is a weakly hereditary disease. So one other just number that always like for people to hold on to is, if I have MS, what's the likelihood that my first degree relatives or my siblings and my children, what's the likelihood that those people would have MS? 2.5 to 3% chance that they would have MS. So there's a 97 to 97.5% chance they won't have MS, but that 2.5 to 3% chance is a lot higher than the general population.
Got it. Linda asks, do each of the DMTs target specifically B cells or T cells? Since there is no way to determine B or T cells driven MS, is there a DMT that targets both or for PPMS?
Yeah, so all of the DMTs do have a specific mechanism of action. And I would say early on, in our, when it was back with the platform therapies, our gluteramine or Copaxone drugs or interferons, that they probably were more geared towards the T cell pathways. And then we start getting Rituxan and Ocrevus, and we start getting more B cell pathways. When you look at something that broadly hits both, what you could say that Lemtrada hits the it's an anti-CD52 monoclonal antibody. Those CD52 receptors are present on both B and T cells. Mavenclad, the oral therapy, to a certain degree hits some both B and T cells. We have to be careful if we don't want to use the sledgehammer approach. If you have a really potent immunosuppressant drug that really hits B and T cells, you can use that to treat MS. We used to use chemotherapy to treat MS, prior to 1993. That comes with a cost. So you're going to open yourself up to infections due to being immunocompromised. So we're getting, we want to be as aggressive as we can without whacking your immune system into oblivion at the same time. So I think she mentioned primary progressive MS. I think one of the challenges with primary progressive MS has been it's just a different animal in some ways. If most of our disease modifying therapies really are in some way anti-inflammatory by affecting these different immune pathways, one of the challenges with primary progressive MS is there's not as much inflammation. In some ways, primary progressive MS is a little bit more of a degenerative condition than an inflammatory condition. There's still clearly an immune component, but one of the reasons that our therapies, all of our therapies have been just not as impressive in progressive forms of MS is that our inflammatory target that we're shooting at is just smaller in that form of MS. It really speaks to the need for some different ways of attacking progressive MS. And are really a focus on neural repair or forming new pathways.
Becky wants to know, how does DMT work differently for the different types of MS, and how can one medication be used for both while others cannot?
So a lot of to her second point, a lot of what a drug is FDA approved for may not have to do with the mechanism of the drug. It may really have to do with what it was tested for. So a drug is only FDA approved for something if it's been specifically tested for that form of MS. And it's frustrating, I think, for people with progressive forms of MS because a lot of the drugs seem to be targeting relapsing remitting MS. There are more people with relapsing remitting MS and there's more inflammation with relapsing remitting MS. So it's probably an easier form of MS to target. So that's, I think, sometimes why there's more research dollars put in that to that form of MS. It's not for lack of interest or lack of want, with progressive forms of MS. It's just it's a tougher thing to go after. So again, the different DMTs have different mechanisms of action. But again, when we think about the immune system, there's a lot of sort of overlap. Just, T cells and B cells talk to each other. So even though I'm using a T cell therapy, I may have a downstream effect on B cells. B cells, again, act as antigen presenting cells to T cells. So even though I'm using a B cell therapy, I may be affecting T cells downstream. So it's not that, like, I don't think with our therapies, there's that real clean delineation that I'm only affecting one cell subset or pathway, based upon the mechanism of action of the drug.
We've got another hand raise from Connie. Connie, can you unmute?
Yes, I'm unmuted. Hello. My question has to do around environmental causes. I am a 69-year-old African-American woman and had my first symptoms of MS at 14. As I got into my 30s and got officially diagnosed when technology allowed that, I realized there was at least 10 to 12 other African-American women in my community that also had MS. And some have passed away. So it was interesting to me when someone brought up environmental, that you were talking about low vitamin D, obesity in teenage girls, and Epstein-Barr. I was thinking environmental, like pollution. So can you speak a little bit more to that, please?
Yeah. So, I mean, I think to back up for a second, I mean, so one of I think the interesting developments in the past few years has been the realization that MS is just as common in the African American community as it is in any other community. I was taught in medical school that MS was far more common in people of Northern European descent. Multiple studies have come out recently and said that is not true, that it is the studies have shown that African Americans have really the same risk of MS as Caucasians do. Is it possible that has changed in recent generations? Maybe. It does look like the prevalence of MS is going up, and that may be true for all autoimmune conditions. The idea that pollution might be, one of the environmental factors, I don't think is crazy. So there's this concept of something called super antigens. So this is, rather than an Epstein-Barr virus serving as the antigen that fools your immune system, what if it's a molecule? So some parts of our immune system, you have to have specific amino acid sequences on a virus or a bacteria to fool your immune system. In other parts of our immune system, you just have to have a molecule that looks three-dimensionally enough like something that our body has naturally, that may be what it takes to fool the immune system. The reason I think the pollution idea is kind of interesting is when you look at the first Desert Storm, when we had a lot of soldiers coming back from Kuwait, you had all those nasty burning oil wells, just belching, Lord knows what into the air. You saw a big spike in autoimmune conditions in a lot of those soldiers that came back. And the thought is maybe that some of this stuff that the people were breathing in was serving as a super antigen. Yeah, it is. I think we're learning a lot. So when you think of specifically in the Black female population, well, of the lowest of the low vitamin D levels we see out there, who in the world has the lowest vitamin D levels? Well, Black women have the lowest vitamin D levels. So that may be part of that sort of equation and mystery that's being unraveled.
Thank you.
Yeah.
Let's go over to our Facebook questions. I see Jillian asked, yesterday I heard about benign MS. Can you explain? He states that he came in late?
Yeah. So we've always known that MS in terms of severity is not the same across the MS community. There are people who have much milder forms of MS and people who have much more severe forms of MS. And so benign MS is a kind of a controversial term. Some people said, well, I don't like that term because if you came to have an MS diagnosis, it affected your life in some way that got you an MS diagnosis. So maybe rather than benign, maybe we should just say milder MS. And that's the term I use, that there are people who clearly have milder forms of MS. They're going to look back over their life at age 90 and look back and say, that was a hassle, but it didn't affect my vocation significantly. It didn't affect, what I did in life that much. It was a nuisance to me, but I dealt with it. One of the mysteries of MS is why the difference, and we don't understand that. Clearly there are people who are able to handle the inflammation with MS, and their immune system seems to put the fire out a little more effectively than other people do. I saw a young man today who's relatively recently diagnosed, 23 years old, and he's had very aggressive inflammation on his MRIs, but he doesn't have a lot of the more severe tissue damage. He doesn't have black holes or atrophy, and something about his immune system just seems to be able to put that fire out. Doesn't mean we want to ignore it. We want to get him on treatment and put the fire out altogether, but he seems to be, something in his immune system seems to be able to handle the attack a little bit better than other people.
And we have another question from Petrina. She says that she's currently on Ocrevus, and if she is T-cell driven with MS, does that mean Ocrevus won't work for her?
No. So again, remember that B cells do more than just make antibodies. They coordinate the T cell response also. And so there is a lot of thought that part of the way that Ocrevus works is actually indirectly through T cell mechanisms, even though it's a B cell therapy. So no, I wouldn't have her worry about that.
And Sean asks, will a high antioxidant diet play a role on the cellular level of someone getting MS or someone with MS? I'm sorry.
I mean, theoretically, yes. And there's some animal models out there with things like turmeric in the animal model of MS showing if you load an animal up with turmeric there and you give them the experimental version of MS called I'm sorry, experimental allergic encephalomyelitis, that they appear to either not get it or have a much milder course. So we know that oxidative stress is the downstream effect of inflammation. If I kill one cell and that cell dies and it releases all of its contents, that tends to be oxidative. It generates more inflammation downstream. So if I have something that's antioxidant, in theory, that would be a good thing. When you think about drugs like Tecfidera and Vumerity or dimethyl fumarate, part of their mechanism, they work through these funny NRF2 pathways, and those are largely antioxidant pathways.
Darcy from Facebook wants to know if you could share your thoughts about recent observations in medical literature regarding a possible increasing relationship between COVID infection and the onset of MS.
Yeah, I think the jury's still out at this point. So clearly, like any viral infection, COVID is, if you get a COVID infection, your immune system is going to rev up to fight it. I think there's a decent chance that your MS symptoms are going to act up during that time. We've had a handful of individuals who had COVID infections that had pseudo exacerbations, worsening of neurological symptoms, sometimes mild, sometimes more significant due to that infection. And I think that in that way, COVID is behaving like other viruses. It generates an inflammatory response. COVID is a little different though. There's this question of things like cytokine storms with COVID that would be a really big inflammatory response. I'm not ready yet to say that COVID plays a role in interacting with someone's genetics, that it could be that final environmental trigger that could unmask or cause multiple sclerosis. I just don't think we have enough data there quite yet. The other thing I don't think we really have a lot of data on is things like long COVID or long haul COVID is, what does that look like in the MS community? I think we're still figuring out what long haul COVID is in anybody. And so that I think we'll know more as time goes on.
And I'm going to hop back over to the Q&As for a second. This question is a little unclear to me, but Gail says, who and how can you tell your B and T cells? Not sure what she's asking.
Yeah, so I think she's kind of probably speaking to that. How do I know how my MS is driven? Am I B cell driven, T cell driven, both? We want to know the answer to that question as well. We don't have the technology to do that. Again, if you were to look at an active MS lesion biopsied under a microscope, you could get some of that information, but that's not the way we want to go about getting that information. So we don't have that technology quite yet.
And an anonymous attendee says that I have a friend on IVIG therapy and it seems to be helping her MS to behave. What is IVIG therapy?
Yeah, IVIG is an interesting MS treatment. So IVIG is pooled antibodies from a large number of blood donors. So there are probably 8 pharmaceutical companies that manufacture IVIG. So they have a pool of blood donors. These blood donors are screened for HIV and hepatitis and other infections. Once they're clean, they're screened every time they donate blood. That blood then is heavily processed. All the red blood cells, white blood cells, platelets, everything is taken out except for really the protein component, which is mainly the antibodies, the immune globulins. That goes through a purification process. By the time it's ready to be used in a patient, it's a sterile white powder. It doesn't look like a blood product at all. That when it's ready to be used, that's reconstituted into a liquid form and given intravenously. In kids, it can be given subcutaneously. The reason IVIG I think is so interesting is it's used at both ends of the immune spectrum. So a lot of its use in the United States would be in children with congenital immune deficiencies. These kids are born without antibodies, so we just give them antibodies for the rest of their life. And then at the other end of the spectrum, we use it in people who have a relatively overactive immune system. So it's used to treat things like Guillain-Barré syndrome. It can be used on a regular basis to treat MS. Why don't we use it more in multiple sclerosis? The biggest reason is because it's not FDA approved for MS. There are lots of studies from around the world that say it does work when given on a regular basis in multiple sclerosis, but it's not FDA approved and it is really, really expensive. When we use it in MS, we are using it off-label. If we use an off-label drug to treat any health condition and it's a cheap off-label drug, your insurance company is probably not going to say too much about it. If it's an expensive off-label drug, they're going to suddenly care and they're probably going to really make it difficult for us to use that. Because there are multiple companies making IVIG, it is exceedingly unlikely that one of those companies is going to step up and do a large phase 3 study to get us the big data we need to get FDA approval for IVIG and MS. So it is used, it's off-label. Usually it's something that people have kind of evolved into for a number of reasons. Maybe they had trouble with side effects with other drugs, or maybe they used IVIG to treat a relapse and it worked really well. And they said, well, let's see if we can get this covered on a monthly basis. So yeah, it does work in certain individuals. It's an interesting compound.
So Sue says, I am originally from London, Ontario, which is considered a MS hotspot. Any ideas why so many people from there have MS?
Yeah, so in general, the further away from the equator we go, the higher your MS prevalence is. Before I came back to the Southeast, where my family's from, I was in Spokane, Washington, and that's another one of those kind of high prevalence areas. We're really evolving in the way we think, because part of the answer to this question used to be that areas like London, Ontario, and Spokane, Washington were very racially homogenous areas, lots and lots of Northern European people. which we always thought was our high risk group. Well, now we've got data saying it seems to be just as prevalent in people of African descent. So I don't know how we square that. I mean, we've always had these hotspots, Minnesota, places in Canada, Spokane, Washington. So yeah, there was a thought years ago that, you know, maybe it's all vitamin D deficiency, or you're further north, you have lower sunlight exposure. But if you look at vitamin D deficiency in the MS community in Florida or Puerto Rico, there's just as much vitamin D deficiency there, even though they have more sunlight exposure. Part of the vitamin D story in MS really is genetic as much as it is sunlight exposure. So yeah, we know that those hot pockets are out there, and I'm not sure that we have all of the answers to that right now.
Ernest from Facebook asks, I did HSCT in 2019. MRI is stable, but my walking is getting worse. Does this mean that I am progressing? And if so, what's the best medication to consider?
Yeah, so HSCT, just for the other folks, is, you know, hematopoietic stem cell transplantation or autologous stem cell transplantation, basically giving the person a new immune system using their fresh cells that don't have the memory to attack the brain and spinal cord. So I think progression in someone after HSCT is really almost the same discussion as progression in someone on a highly effective therapy, Tysabri or Ocrevus or something like that. We think part of the progression we see even after highly effective treatments is due to something called loss of neural reserve. Neural reserve is how much you can injure your brain or spinal cord and get away with it. If we have less neural reserve, we're not able to handle that injury. So think of all your MS lesions as injuries in the brain or spinal cord. As we age, we all lose neural reserve. It's just normal human biology, and it really starts at about age 30. So those old MS lesions that maybe weren't giving you much trouble, as we get older and lose reserve, now they're giving you more trouble, and it's causing progression of symptoms. So in that way, maybe progression in someone like this individual after HSCT really is not the MS changing, it's the body's ability to handle the prior injuries that's changing. I don't know that, because that's not driven by inflammation, I don't know that, you know, that there is a perfect disease modifying therapy. That doesn't mean we won't try something, but what it really speaks to is we need something that repairs damage in the brain and spinal cord, or reroutes around old damage. And we're getting closer. We're not there yet, but we are getting closer.
Margie's had her hand raised for a while. Can you unmute, Margie? Margie, you're still muted. Can't hear you.
Yes, does that InterStem work for the bladder issue for people with MS?
Yeah, so just so folks, the InterStem device is an implantable, kind of almost like a pacemaker device that rewires your bladder. It can be used for people who can't empty their bladder, or for people who have an overactive bladder. It does work. You want to be very thoughtful about, you know, getting that. It is a surgery. It's a permanently implanted device. There's a trial device. So when you work with a urologist to look at one of these, they're going to, you know, do a trial with a temporary device to hopefully show you that it does what you want it to do before you have the permanent device put in.
But is it that effective? Somebody said it's only 60% effective.
I've seen it make a difference in people's quality of life in a positive way. I have not seen it get rid of all the symptoms. Most of my patients who have them have been moderately happy with them and said it was worthwhile. I've had a few individuals who said, boy, this just hasn't done what I thought it would do. I think the real key is working with a urologist who's very, very familiar with these devices and has put a lot of them in. And so that you really, if you commit to having that device, and you know what you're getting after surgery.
Well, I'm 72 years old and was diagnosed 7 years ago from waking up in the middle of the night to go to the bathroom. And I'm wondering if it's really worth it at my age.
I would certainly make sure you've exhausted every other option out there, for managing bladder symptoms, before you commit to it. And again, they should do a trial, with a temperature, so you shouldn't have to guess, what the results are going to be. If after you do the trial, you should have a pretty good sense of what things are going to be like.
Because you don't really live that long with MS, isn't it like 78 years old?
So that's a great question. So if we're just looking at cold hard numbers, the life expectancy for a person with MS is about 7 years shorter than the general public. But I think that's a little misleading. If you have lived to be in your 70s and you have MS and you are otherwise in fairly decent health, chances are you probably have the same life expectancy as anyone else. That 7 year sort of drop in life expectancy, part of that is driven by young people who have very, very aggressive disease. If you're 45 years old and you live in an assisted living facility with MS, that's a rough thing. I mean, you're at higher risk for urinary tract infections and skin breakdown and swallowing issues. That small subset may be largely what's driving some of that 7 year decrease.
Yeah, well, I was recently diagnosed with scoliosis too. So now I'm walking with the walker because of the scoliosis. So I was kind of thinking between that and, your spine and your brain, and if the Medtronic thing can really get this signals to work, or with the scoliosis, it would just probably not be that effective.
Well, the thing with the InterStim device is it's bypassing both your MS and your scoliosis. So those are problems upstream with your spinal cord. What the InterStim device is going in down below that and saying, okay, if you can't get the signal from brain and spinal cord to your bladder, we'll just give you the signal from the InterStim device by hooking the nerves up from down below.
Yeah. And all this stuff I hear people talk about, they think it's the pollution or the food additives. When this multiple sclerosis was diagnosed, like in the 1800s, we didn't have all the, airplane and train and car pollution, and everybody pretty much, they were all eating organic and they were pretty much healthy because they had to walk to get wherever they wanted. And you had, when you worked, you were on your feet basically. And, I don't see it as it's in any of the food additives or the air pollution or the air quality. And they all got enough sleep because electricity hadn't really been invented. So
I think there's some truth to that. MS has been around probably since biblical times. I mean, clearly we know cases in the 1400s that are really well described. But I think that the path to having MS, there are a lot of different paths. Some that probably have nothing to do with pollution or food additives. But it does look like the prevalence of autoimmune conditions may be going up. I think that the way we eat now looks very different from the way we ate, even 50 years ago. And I think there are a lot of, this is, my wife's a pediatrician. This is her speaking through me. This is her soapbox. And a lot of the crap that we're eating these days, I mean, just is not healthy. And I think if we could get back to eating the way we ate, more mom and pop farms, less processed food, I think all of our health would be better for it.
well, all you have to do is look at the Woodstock pictures. There's not a fat kid.
Nope. Nope.
When I was going to school, there was maybe one pudgy kid, but nobody obese. But the ones that dieted back in the 60s were older women like grandmas who were going to weddings,
Very true. My wife and I always comment, when you watch movies from the 1950s and 60s, we were generally a thinner group of people back then.
Yeah, well,
Let's jump on and see if I could talk to you all day. We have interesting stuff, but let's see if there are any other questions out there.
Yeah, we do have a few more, and it is at the hour mark. How much more time do you have, Dr. Thor?
I can go 10 more minutes.
Okay, so Gail wants to know if a negative life event can trigger immune response.
So when we have events, bad things happen, we talk about the fight or flight reaction. So, our immune system does rev up to a stressor. You do that enough, and it probably can eventually kind of start wearing itself out a little bit. You may be more prone to getting sick just because your immune system has been on alert status for longer than it can maintain that. So the immune system can go either way in response to stressors. It revs up initially, but may actually come back down in a negative way with chronic exposure to stress.
And Doris says in the Q&A, she also has her hand up. I don't know if she's going to be asking the same question, but in case she does, I'll just kill two birds with one stone. How does Ampyra work with DMTs like Ocrevus?
So you can use those together. Those are from two different treatment boxes. Think of Ampyra as in the symptom management treatment box. It's designed to work on potassium channels on naked nerve fibers or demyelinated nerve fibers to hopefully make those nerve fibers work better. So it was specifically looked at to improve walking speed and leg strength. It's not an immune therapy. It's doing nothing to your immune system. It's just helping you function better by working on those potassium channels. So you can absolutely use a DMT and Ampyra together, two very different goals.
And Margie says in the Q&A that she had never had mono or was near someone with it, but she got MS, and she wants to know how.
Yeah, so the Epstein-Barr story is not the story. It's an important story, but I think, again, there may be other pathways, other viruses, other antigen exposures that could lead you down the MS pathway. That said, there are a lot of people who never recall having mono, but they've still been exposed to Epstein-Barr virus. If you check Epstein-Barr virus antibody levels in humans, you'll find Epstein-Barr virus antibodies in 95 to 97% of individuals. And a lot of those individuals say, I've never had mono. So you can have exposure without actually getting the mono illness.
So is that like everybody went to high school and somebody in the high school had it, even though they weren't your class, it was in the hall? You know what I mean?
Correct. So Epstein-Barr virus is what we call a ubiquitous virus. It's everywhere, and almost every human will be exposed to it at some point. Whether you get mono or not is the question, but you could still have antibodies to Epstein-Barr virus without having had a big bad mono illness.
One woman who has MS said she shared a very small bedroom with her sister who got mono as a teenager. She said, I never got mono. I got MS, and she never got MS. But she was the one that had the mono.
But realize too that with the environmental exposures, you've got to have the right genetics too. So millions and millions of people have had mono, but only a small subset are going to get MS because those other people didn't have the right genetic background to have an autoimmune disease.
Jim wants to know, he says, I've been on Tysabri infusions for 8.5 years and have been seeing that Tysabri is offered as an injectable in the European market. What are your thoughts on this, and do you think it will ever be offered in the US?
Yeah, I think so. The injectable form of Tysabri did get approval in Europe. I don't know if they're going to try to get approval here in the US or not. They talked a lot about it a few years ago, but then I have not heard as much. I think it's very possible that it might. I think there's good and bad to that. The good is it obviously could be a lot more convenient if it was something patients could do at home on their own. I think the challenge and the potential bad is we've got to make sure we maintain the safety monitor. We've got to make sure people are still getting regular testing for JC virus antibody index. If we have someone who's doing their Tysabri self-injection at home and they disappear for a year and don't get their regular JC virus antibody testing, that could be a risk for PML. So yeah, I think there's a chance we will get it. We just make sure we do it right.
And Doris dropped another question in Q&A. I believe she's asking, does Ampyra cause insomnia and constipation?
I've not seen constipation as a big side effect with Empira. Constipation is really common in people with MS, and sometimes it's the way that the MS has affected GI motility itself. A lot of other medicines can do it. So your any of your bladder medicines in that are what we call anticholinergic, your oxybutynin and your detrols can are big risk factors for constipation. Baclofen can be constipating. The I'm trying, what was the first part of the question? We talked about insomnia. If you get Empira too late in the day, yes, I've seen it give people an energy boost when they don't want an energy boost. We try to keep Empira as much as we can 12 hours apart. So sometimes we have to adjust that early morning dose, maybe a little earlier if possible, so that the afternoon dose is not too late in the day. But the other thing I've done in some people is just drop the late day dose so that we don't interfere with sleep.
And Patrina from Facebook has another question. She says, if you have lesions on your brainstem, is there a chance of getting a seizure? She said she recently had an episode and she's not sure if it was a seizure or a panic attack.
Yeah, so seizures usually are a result of something that's bothered the brain above the brainstem. So brainstem lesions usually wouldn't be the sort of the source of seizures. It's lesions higher up. You really can't count on there being a lesion or not to say whether an event was a seizure, because there's just not great correlation between where the lesion is and whether someone's had a seizure or not. Determining whether an event was a seizure or not really is more based upon the story. A lot of times that story needs to be from witnesses. What did we see the person doing? Because the person themselves may not remember or may not have they may have been altered in their level of consciousness. An EEG or brainwave tracing, ideally, we'd love to catch an event during an EEG. That pretty rarely happens. So what you're really looking for on the EEG is the smoking gun. Is there what we call an epileptiform discharge or a little sort of electrical spike that suggested, oh yeah, that's your seizure focus, and this person would be at higher risk for seizures.
And Teresa says she's currently 64 and has been injecting Copaxone for 12 years. Due to weight loss, she doesn't have, or she hasn't many places of fat left, limited to hips and thighs. She said she just stopped stomach because the nerves just flare up and hurt. Gabapentin helps, and she's thinking of asking her neurologist if she can safely stop. She says she's terrified she'll decline rapidly and end up in a wheelchair. And her question is, what's to stop those white cells from attacking once the wall is down?
Yeah, so some good news. There was a study presented at the Consortium of MS Centers back in the springtime that looked at this issue. So they took a large group of people, 60 and above. Most of them were either on Copaxone or an interferon. And with those people's permission, they randomized them to either stay on their treatment or stop their treatment. So one group stayed on, one group went off. They followed them for 2 years. At the end of 2 years, there really was not a significant difference between the two groups. The good news is both groups did well. There was little progression. There were very few relapses, few new lesions on MRI. So this is a discussion we're having with patients now who are struggling for either financial reasons, physical reasons with staying on their injectables. What this study would suggest is that you probably could safely go off of treatment. Again, everything's individual, and what I'm having our folks do if we stop their disease-modifying therapy after age 60 is probably get another MRI of the brain 6 months out, just to make sure that nothing's changing under the surface.
And an anonymous attendee says they're from Jamaica and was diagnosed with MS 6 years ago. Said that I have recently started having frequent UTIs. Could MS be the cause of this?
Absolutely. So MS can affect the bladder in a number of different ways. One of the things that it can do is cause a bladder to not empty completely. If you have urine sitting in your bladder chronically, that is a wonderful place for bacteria to grow. So you want to get that looked into. If you have a bladder that's not emptying completely, that may be the source of your UTIs. It's a really simple test called a bladder scan. It's a quick ultrasound. You go to the doctor, you empty your bladder. They take a picture just under your belly button with ultrasound and see how well you're emptying your bladder. If you are retaining urine and the magic number is 100 cc's, more than 100 cc's of urine would put you into the higher risk group for UTIs. We would want you to get in with a urologist to talk about treatment options for that.
And another attendee says that I was diagnosed with MS in April of last year. My son was diagnosed with Crohn's in January of 2020. Do we need to get him tested, i.e. getting MRIs? She says that I didn't get a lumbar puncture, though I was diagnosed clinically and by MRI. Do I need to get it done?
So just because, that story is not unusual. One family member has one autoimmune condition, MS, another family member gets a different autoimmune condition, Crohn's. His risk of MS is really low, unless he has neurological symptoms that would suggest MS. I don't think I would pursue an MRI at this point. I would get his vitamin D level checked because just really correcting vitamin D deficiency seems to be important across the whole spectrum of autoimmune conditions.
And Jay says, can or should the neurologist perform another lumbar puncture to see if O cell band decrease, to see if DMT is working, or can the O bands disappear?
Yeah, so we cannot use oligoclonal bands to monitor how someone's MS is doing. Once your oligoclonal bands are positive, they tend to always be positive. And so we're not using that over time to follow how people with MS are doing. There are other ways, other things that may help us do that. So one of the areas that has been a topic of a lot of discussion over the past 5 years or so is something called neurofilament light chain, which is a measure of axons being damaged. That may be something we can use over time to monitor how effective a DMT is or how someone's MS is doing. It's just now sort of getting closer to the point of being something we could use in the real world versus where it's really just been a research option before.
And Gail says she wants to know if you can build your immune system with vitamins.
So again, realize you don't, with MS, you don't have an underactive immune system. You're not immunocompromised. Now, certain medicines could compromise your immune system, but MS by itself, you have a specifically overactive immune system. A lot of interest, obviously, from people with vitamins and supplements. The one vitamin we have the best data for is still vitamin D. I mean, we know if we get your vitamin D levels up into the 50 to 80 range, that we do increase the number of T regulatory cells, tend to down-regulate some of the inflammatory T cells. So that's we do want to stay on top of that. We want to check B12 levels. Statistically, there's a little more B12 deficiency in the MS community. Outside of that, I wouldn't discourage someone from taking a multivitamin, with iron for women, without iron for guys. But I think the really important ones are D for sure, and B12. Let's make sure it's not low.
We are at 5:45 Eastern. We have like 4 or 5 more questions that I can see. Are you good to answer those, or do you have to run?
Probably we'll have to have those. We'll have to email those in.
Got it. No worries whatsoever. Bhavya, if you can take a screenshot of those, and then we can get those to Dr. Thrower afterward. But you did answer a majority of the questions though, so that's good. I'm glad we were able to make time for everybody and extra time. Thank you for that.
Absolutely.
So if you guys missed any part of the conference, you can go straight to the Multiple Sclerosis Foundation's Facebook page and watch the live stream after we end here on Zoom. Our next Zoom conference will be next Tuesday with Sherry Benz, and you can just ask her questions, spend the hour with her, and she'll answer any questions or take concerns that you have relative to multiple sclerosis, and that would be on September 13th at 7 p.m. Eastern Time with her. Please be sure to follow MS Focus on Facebook, Twitter, and Instagram for times and access information, and subscribe to our YouTube channel. This video will also be on the Foundation's YouTube channel within the week, hopefully. But we do want to thank all of the attendees who participated and asked questions today. And Dr. Thrower, again, thank you for taking some extra time to get as many questions answered as you possibly could.
Absolutely. Take care, everybody.